Dr. Spillane graduated from the University of California, Davis School of Medicine, completed his residency and fellowship in oncology and hematology at the University of California, Irvine. He has been practicing on the Central Coast since 2000. He is a founder of Surfing for Hope, an organization created to help inspire people challenged by cancer through the positive energy of surfing. Please help me join Dr. Spillane.
Hi. So since she gave me the segue to talk about Surfing for Hope, it's something that's dear to my heart. It's an organization that was inspired by one of my patients who had cancer about 15 years ago and went through surgery, intensive chemotherapy, and radiation therapy. And the whole time he surfed, and he was inspired by surfing and being around the ocean and all that. So we started a nonprofit called Surfing for Hope that raises money for local cancer programs, and we do it through a surf contest that we do at the pier in Pismo, and we have a fundraiser dinner and an auction, and also a health fair, which is coming up in October. And the one thing that I'm very passionate about is our Surfing for Hope. We started a support group for young children whose parents are going through chemotherapy and who are affected by cancer, because I always felt like that was the one group that was always being neglected, and there wasn't a support group for them. So we have a camp that takes place once a month, and a bunch of kids go out there with their parents. And so if you guys are interested in hearing more information about that, I will talk to you about that. So my talk is overview of colon, rectal, and anal cancers. And I was thinking about this when Brian asked me to do this talk, and I appreciate you're asking me to do this. I think he said, do you want to do he goes, we're going to cover the entire GI tract, and do you want to do the upper half or the lower half? And I was thinking, the lower half seems a little bit easier, because the small bowel we're not going to talk about, even though that's the majority of it. And so I think we flipped the coin or something. I'll go, okay, I'll take the lower half. And then he goes, okay, I'm going to go first though, right? So now I'm thinking I've got about 10 minutes since to cover colon, anal, and colon recta. And so I was thinking I'm going to change it, my talk. My strategy is this, okay? I got a lot of slides. I'm going to go through them really quick. I'll pause if there's something. I'll go slow if I think it's something important that you need to know about. And then afterwards, when we're sitting up here, you guys can ask all kinds of questions. But anyways, I'm changing what's that? 25 minutes? Oh, that's not bad. I was going to change the title of my talk to colon blow, because I'm going to go through. I'm going through the small bowel or the lower intestine faster than a gallon of Go Lightly. So, all right. So here we go. There it is in all its glory. So we talk about the right-sided colon, which is the ascending colon, which is on the left side of the screen. The transverse, descending colon. Then the rectum is down here, and essentially it's the same mucosal tissue. The rectum we treat a little differently simply because of where it's buried down here with muscle and other tissue around the sides of it. Anus is at the bottom, obviously. So colorectal cancer, third most common cancer, both men and women, and the second leading cause of cancer-related death. And obviously the most important point on the slide is that maybe more than half the cases could be prevented with screening. And so you hear a lot about screening for colorectal cancer. It's important. Whoops. It says the same thing, basically. Same thing, and this is just kind of gives you a reference with regard to other cancers. Risk factors, as you get older, it's more likely. Genetics, we realize, are very important in terms of having a predisposition. Inflammatory bowel disease, we think diet, and we can talk more about that afterwards at the discussion if you guys want. Smoking, obesity, history of polyps, microflora, which is a really interesting topic, which we don't have time to go into, but maybe in the discussion period we will. The Vogelstein model, I thought remember this in fellowship, this was like one thing we learned in fellowship, this model that was described years ago, that it's a progressive set of mutations that lead to cancer. And again, if you can pick it up early at the polyp stage, you can avoid cancer. Screening for colorectal cancer, I promised I'd put in a screening slide. I thought this would be easy, and I was kind of looking at the NCCN guidelines and all these different guidelines. It's actually pretty complicated. basically, there's different modalities that you can do in terms of screening, and that includes colonoscopy, flexible sigmoidoscopy, barium enema, CT colonography, but also stool-based assays. If you just take your average risk person and look at sort of the NCCN guidelines, while I think colonoscopy is still sort of our standard, they give sort of options out there. And for patients who say, I don't want to get a colonoscopy, you can do stool testing, and there's Cologuard has been recently FDA approved, and so that's one option, and also guaiac testing, et cetera. And there's different algorithms that sort of lead you down to what else you need to do, but you can do sigmoidoscopy and also virtual colonoscopies out there now as a screening modality. High-risk patients, it's sort of a different category, and these are patients with history of polyps, patients with family history or genetics that predispose them to colorectal cancer, and patients with prior colorectal cancer. And this also, and maybe the GI docs can talk about this because you guys are the ones who are doing the screening, but there's a very complicated algorithm. Do you come back in 2 years? Do you come back in 3 years, 5 years, et cetera? When we stage colon cancer, if it's caught early in the polyp stage, that's the best. Otherwise, stage 1 is when it hasn't really eroded into or through the bowel, et cetera, going all the way up to stage 4 where it's traveled to other organs in the body. I'm not going to talk a lot about surgery, except to say that if it's a polyp, which Dr. Meiselman and some of the other GI doctors here in the back there, they pluck those out, and that's all you need to have done. If it's invasive, then the important thing is that it's removed as much as possible in its entirety. And adjuvant therapy is what we do as medical oncologists, and so these are the patients that we see, and the question is, of course, is do they need to go through additional therapy with the sense that we're going to mop up any stray microscopic cancer cells that could be left behind. Stage 1, generally that's the person's most likely cured, so they don't need any additional therapy. Stage 2, it's a little more controversial, and there's some other factors that we take into account. For example, if they had an obstruction or perforation, if they didn't have a lot of lymph nodes that were examined, et cetera. Stage 3, generally those are patients that we're going to recommend chemotherapy to. Am I going too fast or too slow? I don't know. I'm not sure about my pace here.
You're good.
And so the thing about adjuvant chemotherapy, and I thought this was, I'll slow down for this slide because I think in terms of perspective, when I started doing my fellowship 20-something years ago, I remember being at the VA hospitals down in LA, and we would have patients on adjuvant therapy for 2 years, and it was levamisole and 5-FU, and nobody ever got through 2 years. They just get tired of doing it. It's hard to say, hey, you need to go through treatment for 2 years, and so a lot of the advances in cancer care are not so much that we come up with new ways of treating people, is that we find that we can cure them with effective therapy by doing less to them. And I think that goes across a lot of different subtypes of cancer. So since I've been doing this, we've gotten better at curing people with less and less toxicity and less therapy. So that was kind of my slide to kind of give the frame of reference of chronologically how we've progressed. And the important point being here, though, that fairly recently, and I think I got another slide on this. Fairly recently, there's some studies to suggest that we can now make the change from 6 months of adjuvant chemotherapy to 3 months of adjuvant chemotherapy in low-risk patients. And this was published in the New England Journal in March of this year. And kind of the take-home message there in quotes was that patients treated with CAPOX, 3 months of therapy was as effective as 6 months of therapy. And the National Comprehensive Cancer Network, or NCCN, had their guidelines now reflect this, so that for low-risk patients, CAPOX, which is capecitabine, which is a pill that you can take, and oxaliplatin for 3 months is an appropriate adjuvant treatment option. FOLFOX wasn't quite as the data wasn't quite as strong, so they kind of left it as a FOLFOX for 3 to 6 months. High-risk patients, they still recommend using CAPOX 3 to 6 months or FOLFOX for 6 months. Rectal cancer, and I put this slide up there just because the anatomy is important to recognize that the tumor, as it's sort of lodged down there in the pelvis, unlike the colon, where the bowel is floating around in the mesentery, the lymph nodes are fairly well fixed, and the tumor is fairly well fixed, so that it offers us the opportunity to use radiation therapy to encompass, or a radiation field that will encompass the tumor and the lymph node drainage pattern. So for rectal cancer, generally, radiation along with chemotherapy is going to be part of their treatment. And very often we're using neoadjuvant, which is treatment before surgery for rectal cancer patients. Not to talk too much about the surgery, but if it's, Brian was kind of alluding to this too, there's other patients that maybe don't have to have surgery. Nobody really wants to live their life with a colostomy, and so the question is always, can they get away with without a big surgery that leaves them with a colostomy for the rest of their life? So transanal excision is for early cancers, and that is appropriate if it can be removed transanally. An APR is where a patient has a permanent colostomy, and if there's enough, if the tumor is up high enough that they can resect it and leave somebody with enough rectum, then a low anterior resection is an appropriate surgical procedure. So stage 4 colorectal cancer, that basically means when it spreads outside of the colon, gets into the liver, other parts of the body, often lung. This is a fairly complicated topic, which I kind of thought I'm going to probably gloss over, and then again we can go into it in more depth during the discussion period. But I think one important point is that stage 4 colorectal cancer is potentially curable, and I think that sometimes gets lost in the community, and I think there's sometimes a nihilistic approach to stage 4 metastatic cancer, and I think that in the situation with colorectal cancer, these patients can often be cured or at least live a long, long, long time. So I think that's kind of the first thing to mention. And then, like Brian was saying earlier, we often sit down with a team of doctors that includes surgeons, radiation oncologists, pathologists, the GI docs, and we're sort of trying to make this decision. Should the primary tumor be resected? Can we resect the metastatic disease? We have some fantastic interventional radiologists in town here who can ablate things, and there's all kinds of fancy ways of ablating things with radiofrequency ablation, microwave ablation, etc. And so we'll often get them involved as well. The other interesting kind of point that this slide mentions here is whether the tumor is right-sided or left-sided, and maybe Randy can talk more about that when we have our discussion, but that's kind of a newer, maybe very important thing that we are recognizing. And then we look at the mutational status of these tumors, and a lot of times we're looking at what's called RAS mutations and BRAF mutations. And for example, it's not so much maybe prognostic information, but also how we're going to treat these patients. And so as I mentioned on the slide here, so right-sided primary tumors, KRAS and NRAS mutations, BRAF mutations, those patients are probably not going to respond to cetuximab and panitumumab. So that is something we take into account when making treatment decisions. And no talk goes without talking about immunotherapy. And it's not that common that we see this, but again, as Brian was saying, if they have a microsatellite instability or if they're deficient in their MMR, then we will consider using immunotherapy. So again, I don't want to go into too much detail about all these different letters, but there's all these FOLFOX, FOLFIRI, CAPOX, and we love saying these things. For us, it's just like, it's fun. It must be really kind of confusing when you say. So we try to think of a backbone of therapy, and then we're adding stuff to it. And we like to say these are sort of the biologic drugs that we add. So you're not just getting chemotherapy, but you're getting all these cool, VEGF inhibitors or EGFR inhibitors. Patients love to hear that stuff. So that's what all that stuff is. So the Alliance study, this was some data that came out a little while ago, but it is kind of surprising to hear that there's this difference between right-sided and left-sided colon, and we've always sort of knew there was a difference. For example, if you present with rectal bleeding, it's probably going to be on the left side. If you present with sort of this weight loss, kind of wasting situation, those are often the ascending colon or the right-sided colon cancers. But when they looked at this one study looking at metastatic disease, the prognosis was very different. So the median overall survival in right-sided colon cancers was 19.4 months, whereas left-sided was 33.3. The other piece of information that came out of this was patients that were treated with cetuximab, which is an EGFR inhibitor. And these patients were all, I believe, wild type, right? And although I think at the time they weren't necessarily doing all the RAS testing, so there may be something more to this than that, right? So, but in any event, it was kind of a shocking difference between the overall survival in patients treated with cetuximab between right-sided colon cancers and left-sided colon cancers. And the NCCN guidelines now also puts that into their recommendations. And I think, as we were talking about before, those trials that are going forward, we're all now sort of recognizing that that's got to be part of the information that is used to evaluate clinical trial and clinical trial data. Again, I said patients with metastatic disease can live a long time, and so their care gets fairly complicated because we do have a lot of different tools and treatments and options that we use, and so often we're treating with one regimen, and then we're switching to another regimen, and then we're maybe going back, and we're going forward, and we're trying all kinds of different things. So I kind of mentioned some of the different other treatments that you may have heard about, including some of the newer drugs. There's a drug called Stivarga, and there's another drug called Lonsurf, which are the regorafenib and the double T drug there. Clinical trials are always the best thing for these patients. We do send a lot of patients down to you guys at UCLA to see if we can get them into clinical trials. All right, anal cancer. I'm almost done. See, coming to the very end here. So anal cancer, and this is a very confusing thing because people say, "Oh, I've got rectal cancer." They don't have rectal cancer; they have anal cancer. Or people say they're very different diseases, and that's because anal cancer is really derived from that sort of epithelial tissue that is more akin to like skin. So it's squamous cell carcinoma. So it's down much slower, and it's not nearly as common as colorectal cancer, but it still affects a lot of people. And so 8,500 cases per year in the United States, and causing 1,200 deaths per year in the United States. And if you look at sort of how this has been going for years, it actually seems to be increasing, though I think that's going to change, and I think the data is lagging because we do have now a vaccine that will theoretically prevent this disease in the future. So the vaccine is for what's called the human papillomavirus, or HPV, and this is the virus that has been associated with not only anal cancer, but cervical cancer and head and neck cancer, and it's almost at a point where people have been talking about it being epidemic for head and neck cancer. We're just seeing this. So, I mean, and I feel very strongly about this, that we have a way of preventing this, which is a vaccine that has been out, I believe, about 10 years. I don't know if anybody has to do, but it's very underutilized, and there's a lot of political and religious reasons that people don't vaccinate their kids. But not to get into that in too much detail, but the recommendations I have up there are from the advisory committee for vaccinations in our country. And bottom line is people should know about this, parents should know about it, and they should be vaccinating their kids. How do we treat it? Usually it doesn't have a lot of symptoms, but still the majority of patients will, so most of them will present with cancer that's probably not surgically resectable and therefore requires additional treatment, but usually it's curable. And so the thing about the way they used to treat anal cancer is they would just have to cut it all out and leave a person with a colostomy. And that's because even if you get in there and try to cut a little bit of it out, the surgeon will often damage the anal sphincter, which is a muscle. And so they could cut it out, but then you'd leave a person who would just have stool incontinence the rest of their life. So they finally got to a point where they would just do surgery. So that was the standard of care up until the 1970s. And there's something, I believe it's called the NIGRO protocol, which came out in 1970. And this was a groundbreaking change in the way this disease was treated. And they basically found that by giving radiation therapy and chemotherapy, they could cure the majority of these patients. In fact, they did better than patients with surgery. And that's because the cancer cells are just very sensitive to chemotherapy and radiation therapy. And that HPV-associated type of cancer, it applies also to like head and neck cancer, for example. So those patients who develop an HPV-associated squamous cell cancer of the head and neck, they do much better than the non-HPV-associated squamous cell cancers. So that's kind of the good news. And I think it's interesting that was 1974, and here we are, I don't know how many years later, we still use that, and that's still the way we treat this. So we still use 5-FU-based treatments along with mitomycin. So some good things don't change. This was just to kind of show that. So that's on the bottom. That's the breakdown of the presentation. So that's stage 1, 2, 3, and 4. So about half the patients present with localized disease, which is about an 80% cure with chemoradiation therapy. So one of the things that being a community-based cancer center that we've been able to do is meet sort of national guideline criteria for making sure we're doing all the things that we should be doing across the country. And we've been an accredited cancer center by the American College of Surgeons. And part of that is that we've developed is having a survivorship program, and we've done that now through our Hearst Cancer Resource Center. And we're very proud of that, and getting patients in to see our nurse navigator and all the people who run that center have allowed us to do this. And a lot of it is making sure that we don't just kind of leave these patients and not follow them. So it's getting them information about what they should be doing after. And so, for example, in colorectal cancer, there are things that might, and we can talk more in detail about, how much is diet important and other types of things. But for the most part, we follow these patients very carefully and watch them closely, following something called a CEA, which is a blood test, surveillance colonoscopy, and all these different things are important. So for those patients that have had colorectal cancer, make sure they're getting into our Hearst Cancer Resource Center to get into the survivorship programs. I think that's my last slide. So, all right, we'll take questions after. How did I do?
You did great.
Well done.